The next speaker that we have here is Dr. Merve Hasanov. She's a medical oncologist at the Ohio State Comprehensive Cancer Center, the James Cancer Hospital. Sorry, it's a long name. We have a very long name to introduce ourselves. She specialized in melanoma and cutaneous cancer. She completed her medical oncology and melanoma fellowship at MD Anderson Cancer Center, where she gained extensive experience in treating complex cases. Dr. Hasanov research is dedicated to advance our understanding of melanoma and the central nervous system, or the CNS, metastasis, with the focus on developing screening tools, early detection methods, and novel treatment strategy to improve patient outcomes. She has been recognized with the prestigious ASCO Young Investigator Award for her work in developing a risk calculator for brain metastasis in melanoma patient, and has authored numerous scientific publications. Dr. Hasanov also plays an active role as a co-investigator in several clinical trials at aiming to improve care of melanoma patients. So today she is going to be presenting an overview for melanoma, and I think I'm still sharing. So that's good. Then you're up, Dr. Hasanov, and Patty, you back.
Good morning, everyone. Thank you for being here. It's a pleasure to present that introduction to melanoma. I call it Melanoma 101. It's a general overview, not so much in depth. So some of the information our speakers today will go into more details, but this is to give you an overview and general introduction. So this is the outline of my talk today. So we'll talk about melanoma significance, what is the melanoma, types of it, risk factors, prevention, diagnosis, stages, treatment, and monitoring and surveillance, and living with melanoma. So when we look at the significance, it is pretty significant worldwide. The skin cancer is about 3.5 million cancers in 2 million patients per year worldwide. And melanoma is about 5% of it, but when you look at the skin cancer deaths, it's more than 75% of it. And in worldwide, we have 200,000 patients diagnosed with melanoma. And when we look at the US, it's about 100,000 patients every year, and also 9,000 deaths. And when we look at the eye melanoma or uveal melanoma, it's about 2,000 cases per year. So when we look at the lifetime risk of developing melanoma, it's about 1 in 40 to 50 in Caucasians, and it's about 1 in 200 in Hispanics, and 1 in 1,000 in African Americans. And the thing is, the melanoma diagnoses have been increasing, and we see more and more young patients are also diagnosed with melanoma. So what is melanoma? Melanoma is a skin cancer, and it originates from the melanocytes, which gives our skin the pigment of it. And what happens are all melanocytes have changes through that things that we're going to talk in the next slides, and it starts growing and dividing uncontrollably. This is how melanoma develops. And I try to draw this to my patients in the clinic all the time to give the overview what melanoma is. This is the layers of your skin that you're seeing here. And on the top, we have epidermis, and the bottom of it is the dermis layer. So melanoma starts from the top layer of the skin and goes both ways, but it also goes down towards the deeper layers of the skin, because our skin is very thin and it's able to actually break off, and then it can go into the lymph circulation and the blood circulation. At how melanoma spreads and can go to anywhere in the body. So we have different types. Most of my references will be towards the skin melanoma today, but we have different types of melanoma. We have cutaneous melanoma, we have acral, which is under your finger and toenails and palms and the soles. of your feet. We have mucosal melanoma, which originates from the mucosal surfaces, which are inside of your nose, the mouth, the digestive tract, which is like your esophagus, stomach, the bowel, genitourinary organs, vagina, rectum, anus. Those are potential areas that also melanoma can originate. And also we have the uveal melanoma, which originates from the eye. And also, some of you might have heard about, oh, they never found where my melanoma is. And this is called melanoma of unknown origin. And most of the time, we find out that probably you had a melanoma on the skin, and immune system, your own immune system was able to take care of it. But it actually goes into the lymph or the blood circulation and able to spread. And that's when we actually diagnose it. And sometimes we don't really find where your melanoma is and treat you still as as a melanoma of unknown origin. And I'm going to touch base on a few molecular changes. When we say molecular changes, we take the part of your melanoma, the cancer tissue, and then check what type of genetic material changes of the tumor, not necessarily your whole body itself, but we're talking about the tumor itself and what changes are there. So you might have heard BRAF. Almost half of the skin melanoma patients have the BRAF mutation. We also have the KIT mutation and NRAS mutation. And a KIT mutation is seen more in the acral and the mucosal melanomas. And for uveal melanoma, we have GNA, Q, and 11 that are the most commonly found mutations and changes. And why these are important, towards the sum of them, we do have targeted therapies such as BRAF, NRAS, and KIT. And GNA, Q, and 11 are used as the prognostic factors for uveal melanoma. And I divided the risk factors into two categories. There are modifiable ones that you can actually act on to prevent yourself from getting melanoma. And also there are non-modifiable ones that you can't change. That's the luck. So the genetics is one factor that you can't change. The family history of melanoma, SAM mutations like CDKN2A, the skin type, having fair skin, freckling, light eyes, light hair. But I wanted to note that darker skin persons actually diagnosed with a later stage melanoma most of the time. And others are the presence of atypical moles or the many-moles or the weakened immune system. But what you can modify and change is actually the UV ray exposure, ultraviolet ray exposure, which comes from the sun, as well as tanning beds, which was very popular back in the day. And what happens with that UV exposure, your DNA gets some breakage. DNA is your genetic material. And once they get some breakage, there are mutations and changes happen, and that can lead to give the signal to the cell to turn into cancer cell, grow and divide rapidly. And that's most of the time the etiology for the 90% of the cutaneous melanomas. So what you can do to prevent, preventing yourself from the exposure to the UV rays, using sunscreen, 30 SPF and plus, staying away from the sun when it's highest around 10 to 11 a.m. to over 4 p.m. if possible. And I'm using large hats and long sleeves whenever possible, and avoiding tanning beds and the sun lamps. Very, very important. And for early detection, we can do self-skin examination and regular dermatology visits. So I say, keep your friendly sunscreen with you at all times, apply it at all times. It's not just one time a day. Every 2 hours it is recommended. If you're swimming, sweating, reapply it after that. And avoid tanning beds because you're beautiful just the way you are, right? Okay. So, and when we come to the diagnosis, you've all probably heard A, B, C, D, E's. And A is the asymmetrical. When you look at them all, one side is different than the other. And when B is the border. When you look at it, it's like rugged, different, not like round and smooth. And the color, one side is darker, one side is lighter. And when we look at the diameter with the D, so it's like we say that the pencil eraser as the 6 millimeter diameter. If it's larger than that, get it checked. And the evolution is probably one of the most important as well. You had a smaller mole, it started to change, it's bleeding, itching, painful, then yes, it's abnormal and you need to get it checked through your dermatologist or see your primary care physician. And when it comes to the diagnosis, I ask, what is it, where is it, and how I can treat it. So what is it? We need to take a biopsy. There is no other way to know if this is indeed melanoma or not. So there are different types of biopsies. So there's shave biopsy, they get the top layer of your skin. There's a deeper punch biopsy, they get the deeper layers. And there's the excisional biopsy, they get a bit of a larger chunk to try to get it all. And where is it? We use the imaging studies. It can be CT scans of your neck, chest, abdomen area. It can be PET scan that scans your whole body. MRI brain is important because melanoma likes to go to the brain, and ultrasound to check the nodal lymph node areas. And how I can treat it, we combine those, the pathology and also the imaging, and we put you in a bucket, the disease in a bucket, that it's one of the stages so that we can decide what treatment is the right to do. And also time to time, we add the molecular testing, especially if we're suspecting advanced melanoma. So the stages of the melanoma, we use something called TNM, T for tumor, depth of it, not necessarily how large it looks from the outside, but how deep it goes. And it gives us the stage 1 and stage 2, depending on how deep the melanoma is, because stage 1 and 2 is only in the skin. And N is the lymph node involvement, but we're talking about the neighborhood lymph nodes. You might hear sentinel lymph node, where the actually melanoma drains. If it is involved or around the skin of the original lesion, we call it stage 3. And if it's spread to distant organs, distant lymph nodes, distant skin, then we call it stage 4 advanced melanoma. And I wanted to mention a couple of notes here, Breslow thickness, ulceration, and mitotic rate. Breslow thickness, those are in the pathology reports. You might see like, what are those? Why are these important? Breslow thickness is the depth of the involvement of the melanoma, as you see over here. So this is called the Breslow thickness. And the ulceration, when we look under the microscope, how it looks, the inflamed and different, that gives us a bit higher aggressiveness factor. And the mitotic rate, when we look under the microscope again, we see how many cells are dividing and growing. And that gives us a number per the area that we're looking at. And that gives us how aggressive the melanoma is. And melanoma treatment, there are different modalities that we use depending on the stage of the melanoma, as we discussed. I'm not going to go into details of some of them. I will mostly go into details of the systemic therapies, but we use surgery, especially for early stage melanoma from 1 through 3, and for some select advanced melanoma patients. And radiation therapy, we use it for early stage melanoma if there are some high risk features after your surgery, like positive margins, more than 4 lymph node involvements, or your lymph node involvement has surpassed through the capsule of the lymph node and has potentially spread outside. And we use radiation for palliative purposes if for an advanced melanoma situation to control the pain, the symptoms, and sometimes for advanced melanoma patients for definitive treatment, for especially the patients that cannot get systemic therapies. And we have something called stereotactic radiosurgery, which will be going into details later on for brain metastasis management. Immunotherapy use is in different stages right now as well. Stage 2 after surgery, we use it before and after surgery for stage 3 and for advanced melanoma, and similarly targeted therapy as well. And there's a new treatment approval for later on will be talked about, T cell therapy, tumor infiltrating lymphocyte for advanced melanoma patients. And there are clinical trials that we use in melanoma, which are very, very important. So I'll go by stage to mention how we approach treating the melanoma. So for stage 1 and 2 melanoma, surgery is the mainstay. So we start with surgery. So Dr. Contreras will go into details, what we do, how we do it. But after your surgery, we have right now immune therapies available to be able to decrease the risk of recurrence, which means your melanoma coming back. So for these are for stage 2, 2B and 2C patients. This decreases the risk of recurrence by 40% compared to if you don't do anything and just observe and do surveillance imaging.
Sorry, I had to check to make sure that we are speaking. Because I
Okay.
saw the mic on there and I was like,
Okay.
oh no. All right,
Is it good?
I think so.
Okay.
Did I stop it? No, I did stop sharing. Sorry. No, I don't. Still good.
It's good? Okay.
Sorry.
All right. So that was stage 2, 1 and 2. So we do have, talk to your doctor. If you have stage 1 and 2 melanoma, discuss pros and cons of doing immunotherapy after surgery. For stage 3 melanoma, we have too many options right now, too many approaches. So, and this is, one is using the immunotherapy before surgery, using the immunotherapy after surgery, or using immunotherapy before and after surgery, and using targeted therapy after surgery. So many options to choose from. And how do we personalize it? It's actually personalized, right? So depending on the patient, how you're presenting, where is the melanoma, what would be the safest option, if you have additional risk factors to be able to do immune therapy versus are you eligible for a targeted therapy? So all of these are discussed with the surgeon and with the medical oncologist, and we come together as a multidisciplinary team and decide which is the best path to take. But more and more, we are trying to move towards the treatment, immunotherapy before surgery because of the really good outcomes that we're seeing in the new information that we're getting from our trials. So what is, I put something here, you're gonna hear adjuvant, neoadjuvant. Adjuvant means after surgery. Neoadjuvant means before surgery. Why, what is it to do with this? Why are we doing this immune therapy? So after surgery, doing the immunotherapy after surgery, as I discussed, melanoma can travel through the skin layers and they can contact with the lymph system and the blood circulation, and they can break and go into negative margins. Means that we got it all, but melanoma is smart. They can break off and then go into the lymph circulation and the blood circulation and can spread. Despite you have perfect surgeries, everything is out. So that's why we're doing this prevention measures. So after giving the immunotherapy after surgery, we assume that you have tumor, proteins, material, actual cells might be left in your circulation. And our goal is to activate your immune system so that they can go find the cancer antigens, cancer proteins, and the cancer cells itself, go and kill them, and then make memory of that presence so that whenever they come in contact with the melanoma cells, they can find and kill them. And doing this beforehand, before the surgery, there is a lot more cancer to look out for the immune system, right? So there is a lot more to recognize. So the hope is to be able to boost the immune system and have that cancer recognition a lot better. And also sometimes we see complete treatment of the tumor at the time of the surgery. So it's completely gone. And that gives us an information about how well you're going to do in the future, and also how likelihood of the cancer from coming back versus not. So just given a few numbers, doing the immune therapy or the targeted therapy, as we talked about with the BRAF and the MEK inhibitors. So we are decreasing the risk, the odds of melanoma from coming back for about 40 to 50%. And doing this beforehand, as I mentioned, it gives us a lot of information. There is more chance that the immune system is trained for cancer. And the odds of reducing the melanoma from coming back for about 40 to 60%. And this is compared to, in some cases, doing the immunotherapy afterwards. So, and the only caveat to that, we have information for about 1 to 2 years from your surgery. So these studies are on the newer side compared to the ones after surgery. So we don't have the long-term data and the information yet. But so far, the 1 and 2 year evaluations are fascinating, so that we're trying to move more towards doing the immune therapy before surgery, and still trying to figure out, do we need to continue it afterwards versus not with our studies that are ongoing. And when you come to stage 3 unresectable and stage 4 melanoma, we have still immune therapies. We have targeted therapies, as we mentioned before, and we have tumor infiltrating lymphocyte novel therapy. And we have something called TVAC injections. And I'll just mention chemotherapy briefly, and then we're not going to open that page again, because melanoma is not really sensitive to chemotherapy. It doesn't respond pretty well. Its response rates for about 10 to 15%. We only use it rarely if we don't have any options, or if you're trying to bridge that gap of the time from one treatment to another while waiting for a trial or a new treatment or another, so that we can have you be on the treatment. But we don't really have great responses to chemotherapy. So what is TVAC? It's a modified herpes virus. It's kind of a virus. It expresses a growth factor for immune cells. And we do it to the injection directly into the tumor, into the cancer. And compared to doing that growth factor injection alone, it has improved the survival lifespan more than 20 months for melanoma patients. And we have targeted therapy, as we mentioned, and the most commonly used one is the BRAF and the MEK inhibitor. And that is only used for the patients that has the BRAF mutation, and it is taken as pills. Response rates are pretty robust, about 70%, and we have more than 90% of the disease control rate. But the caveat with that, if you have high burden of disease, our response rates drop. And also, most of the time, cancer develops resistance to these therapies. So median duration of the response in the body is about 12 months. Again, this is median. Some patients do better, some patients do worse. And in the brain, it's about 6 months. And the common side effects is the fever, chills, sensitivity to light, joint pain, liver enzyme elevation, nausea, rash, and the heart toxicity. And we have others, as I mentioned in the very beginning one, the KIT mutations, and we have pills towards that KIT mutation. And then NRAS mutations, we have pills towards that as well. And immune therapies, again, come into play here. We have, the way it works is, we put brakes. Normally, we have brakes on our immune system. And then with these blockers, we take the brakes off. So our immune system is more active and can multiply in number and recognize the cancer better and kill them. And it is given every 3 to 4 weeks. We have different combinations, different names. You might have heard ipilimumab, nivolumab, pembrolizumab, or Opdivo, Yervoy, Keytruda, more familiar. And Opdualag is another new one. Our response rate's about 40 to 60% in the body and 20 to 55% in the brain, depending on the combination or the immunotherapy of choice. And we have high-grade toxicities, which means the really bad toxicities that leads us to interruption of the treatment or stopping the treatment, giving you steroids, is about 10 to 55%. We have durable responses with immune therapy. It can last 6 years and more for some patients, and some patients that have received immunotherapy has not progressed again, has not had the disease getting worse again. So the toxicity comes from the active immune system, because we're activating your immune system. So it can go attack your skin, you get a rash. It can go attack to your muscles, you get a fatigue. It can go attack to your thyroid gland, you get a fatigue, and you need to take thyroid medication. Similarly, liver inflammation, kidney inflammation, lung inflammation, shortness of breath, cough, bowel inflammation, you can get diarrhea. It can affect basically any organ that you can imagine in your body. So what I say, we don't know which side effects will happen to you and when. So it's just, we know what is the odds of this happening in a high risk, high degree that we give you those numbers in general. Some patients do pretty well, no side effects. Some patients end up in the hospital requiring additional tests and treatments to be able to recover from this treatment. So TIL therapy, I'll leave it up to Dr. Wood to go over in the afternoon. It's a novel treatment that is recently approved for melanoma, and it is approved after immune therapy and the targeted therapy with about 30% response rates. Just quick touch base about the uveal melanoma stage 4. I know we have talk about this. About 50% of the patients with the uveal melanoma develop metastasis, and uveal melanoma likes to go to the liver. And overall survival has been worse than the skin melanoma, unfortunately, for these patients, for about 50% of 1-year survival. But we have had a new approval which has improved these numbers. It is called tebentafusp, and it is a treatment that bridges tumor and the immune T cells together to improve the cancer cell killing. And it is only for select patients. We look at something called HLA. It's a protein in your body that we check. If you have that, then we will be able to give that treatment. And it is given weekly. And we have some liver-directed therapies and immune therapies that will be covered later. So a little touch on the brain metastasis. We have a little more talk on that later. So it can present with some symptoms, or we like to diagnose them early and when they're asymptomatic. That is why we're doing MRI brains in melanoma. But you can have headaches, changes in vision, sensation, leg, arm weakness, seizures, changes in memory and balance. Leptomeningeal disease, another term that you might have heard, it's the lining of the brain and the spinal cord where your nerves are, and also the fluid in between them. So when melanoma spreads to there, and the treatment includes a few different modalities. So radiation, that will be covered later on, surgery for large and symptomatic brain metastasis, and systemic therapy. Immune therapy and targeted therapy is very effective, especially when they're small and asymptomatic. We use chemotherapy only in select patients, and there are clinical trials that we combine different modalities. And clinical trials is very important. What I say, all of the treatments that are available right now to be used came from clinical trials. Because they were tested in the clinical trials, we're able to offer to all of our patients. Please do consider participating in the clinical trials and ask your physicians if there's any available trials. And little touch on the monitoring. So you've got your melanoma out, and you're redeemed. There is no evidence of disease in the scans, and in the surgery, you're doing your immunotherapy versus just the scans. So how we follow up, you follow up with medical oncology, dermatology, and depending on the stage of your disease, surgical oncology and the radiation oncology. But we do imaging studies, depending again on your stage, might include a CT scan of your chest and abdomen area, and also MRI brain, an ultrasound of your lymph node basins. And we do visits every 3 months for the first year, 4 months second year, 3 to 5 we do every 6 months, and then annual thereafter for medical oncology. And for my last notes, so living with melanoma is hard. Even if you had your melanoma out, or it's like chronic disease. We're doing treatments and you're living with melanoma. There's a lot of emotional impact to that. really promotes anxiety, fear of recurrence all the time. But support networks are very important. Family and friends probably are the best, but we have also some support groups that can be touch base on later. And lifestyle adjustments are always asked. Oops. I am not sure what happened, but okay. So I'm gonna finish up last two. Okay. So that because these are asked a lot in the office, so I want to mention those. So diet, exercise, healthy lifestyle, those are all important. I always tell patients, focus on what you can eat while you're undergoing treatment and don't make drastic changes while you're trying to nourish your body. But if you're a survivor, so healthy lifestyle, diet, exercise, they're all very, very important. And also, what is dietary changes? The only thing that's scientifically evident that we know right now is high fiber diet while you're on the immunotherapy is associated with a higher response rates. So there you go. That's one thing that I generally recommend. Supplements. I don't recommend supplements that we don't know scientifically how it goes through the liver, the kidney, what are the side effects, and how it is effects on together with the immune therapy or targeted therapy. So I recommend stopping those supplements. Multivitamins are generally okay, but the others, there is risk of toxicity, especially when you're on or off the treatment. So the vaccinations, that is also other questions that I get asked quite often. So it depends. Every patient, every person is different and their case, and it depends on what treatment you are, what disease of the stage of the disease you are. So I recommend asking your physician. But my rule of thumb, generally, if you're doing okay, not having toxicity from your treatment, I recommend doing this in between your treatments, infusions especially. So in the middle of the cycle, and separate them out. Don't do them all at once. But this is something that needs to be asked to your physician, and it all differs, the recommendations depending on how you're doing. So with that, I want to thank you all for your attention, and I'm here available if you have any questions later on. Thank you.